The reason I got interested in this, and the reason I got interested in heart rhythm management was about 15, 20 years ago when I first started being involved in training in heart rhythm medicine. There were about 30 heart rhythm specialists in the UK. And there was a professional and public view that that was okay, that was all that was needed. And indeed, when I started specialising in heart rhythm care, my bosses said to me, "Why are you doing that? There's going to be no new jobs in heart rhythm management, they're all full now." But the reason I was interested, and I think I've told this story before, is when I was a registrar, I went on to coronary care in Hull, which is where I was working at the time, and there was a 16-year-old girl who very sadly was brain damaged from having had a prolonged cardiac arrest. And people have cardiac arrests, and it's very unfortunate, and sometimes you can't do anything about it. But the thing that really struck me was that her sister, who had had a cardiac arrest 3 years before at the age of 8, and they had a reversible or certainly treatable cause for this, but she'd never been screened and never been investigated. And that really struck me that we were not really organised enough to identify patients at risk and do something about it. I then moved down to St Mary's, and we were just beginning to put in implantable defibrillators, which were the treatment for these kinds of risks. And at the time they were highly restricted, to the extent that we had a guy come in and survive a cardiac arrest. We requested a defibrillator, and our senior manager said, you can't do it, we're not giving permission because we can't afford it. So we asked them to come down and explain this to the patients, and of course the patient very obligingly had a cardiac arrest while the manager was speaking to them and was successfully resuscitated and had their defibrillator the next day. But it really struck me that there was a disconnect between the patient's experience and what the public and professional conception was, not necessarily within heart rhythm specialists, but the wider profession. Then there came some really important changes to the National Health Service. So the first example of this was the National Service Framework, which really determined what our standards would be for cardiovascular medicine. So they gave us standards for care, standards for waiting times, and standards for the discharge and follow-up of patients. However, what they forgot to do in that is include anything about heart rhythm management. And the collective fury and anger about this amongst the patients and their carers and the professionals really prompted, I think, was a big force to merge the Arrhythmia Alliance and get people working together. The Arrhythmia Alliance lobbied government, and as a result, Chapter 8 was formed, which was a bolt-on to the cardiovascular NSF, which basically specifically concentrated on arrhythmia management and made a big change to the way that we look after patients. And I think it was probably the first time that professionals and patients sat in the room together and drew up these guidelines for the way that patients should be cared and expect to be cared. So the patient's voice began to really change the way that politicians and professionals expected to manage them. At the time there was a lot of professional anxiety because doctors, or some doctors, felt, well, are the patients going to be driving the agenda here? Are we losing control? And what they forgot is that the patients were always driving the agenda because we met them every day in clinic, and it was the patients that told us what they wanted, and we just went and did it. And what was really happening is that the doctors were the interface between the patients and the politicians, and of course the politicians quite understandably didn't really listen to the professionals because they thought that we had a vested interest. So it was only when the patients started directly interacting with government that things really began to change. One of the next important things was the NICE guidelines, which firstly focused on implantable defibrillators. So addressing the issue of the patient that was sitting there having survived a cardiac arrest and was still denied having an implantable defibrillator that would save their life later on down the line. And this was a really important step forward in setting standards for what patients should accept in terms of prevention of their risk of sudden death. It set out clear guidelines for who should have a defibrillator, and even accepted that patients who were at high risk of cardiac arrest, who had not had a cardiac arrest, deserved and warranted that treatment. Then we had the NICE guidelines for atrial fibrillation, and I'm not going to dwell on these because we've got Jane Cowell, who's from NICE, talking in a few minutes, but they set out clear guidelines, for example, for stroke management. However, the really stroke prevention, the really interesting thing, which I can't show you really, was that it really had very little impact on the way that doctors prescribed their stroke prevention. So I've got a graph here which basically shows, which you're not going to be able to see, but it shows a flat line in terms of the number of patients on anticoagulants and the number of patients on antiplatelets until about 2008-9. So some 5-6 years, sorry, 3-4 years after the NICE guidelines came out. And this is work done by my colleague John Robson, who's a GP in North East London. And essentially the message is that the guidelines are all very well and good, but you then have to get the message out to the clinicians and the carers, what the guidelines are, why they're important. And that's where the Arrhythmia Alliance comes in the meetings that John's described earlier on, completely just continually battering down the doors of patients and people's resistance to these highly effective and proven treatments. The new NICE guidelines are coming out very soon, and they're under embargo at the moment, so I can't talk about them, but we certainly know what was in the draft guidelines, which is simplifying stroke prevention even more. Something I'm really proud of is that it looks as though they may remove any age limits from those guidelines. So in 2006, they restricted the care of patients over 65, which I thought was ridiculous, because many of my patients I had an email a few months ago from an 85-year-old who'd just gone to Everest Base Camp, thanking me for doing their AF ablation, because it allowed them to continue doing their stuff. And it also sets a time limit for care, because patients have continually told us how frustrating it is for them to spend years and years getting through the treatment pathway. So it looks as though the new guidelines may set a time limit where we expect patients to then move on to the next stage of treatment if the first stage has failed. And I think that's going to be really important to patients who find it very frustrating suffering for months and years. How was all this done? Well, I'm often asked this by colleagues in Europe and around the world, because they can't believe how successful we've now been in the UK in getting arrhythmia high on the agenda and improving the care. And the answer to how it's done is really, really simple. First thing you do is find someone like that, who is motivated, cares, bright, and highly driven. And they are fundamental, so your patient carer is fundamental to the success of this initiative. The next step is to ask her to marry someone who carries her along on their shoulders during the initial years, Charles, who very sadly a few years ago died of a sudden cardiac arrest. But up until that point, he had been the heart of this whole organisation, supporting Trudy and supporting us in getting this whole thing going. It also helps to have a couple of daughters that are bright and involved and helping out with the whole system as well. And you also need a few friends and colleagues who are really bright. Joe's hiding up at the back there, who will also keep that momentum going, and all the staff in the Arrhythmia Alliance are incredibly important to her. And then having influential people like Glyn, Fabrice, and a number of other lords and MPs and ladies who are incredibly important to keeping this high in the mind of the public and the press. So the future. I think it's going to be, we have a good future ahead of us, but I think it's really important. We're going to have to push very hard to get the new NICE guidelines into clinicians' minds and into patients' minds so that it actually has some impact. And I think the Arrhythmia Alliance will be very important in that. The Arrhythmia Alliance really wants to improve access to automatic external defibrillators, because there's no doubt that these early access to basic life support and cardioversion makes a big difference to people's outcomes after cardiac arrest. And many people live long, long lives after cardiac arrest and a successful resuscitation, so it's very important. And one of the key things is to try and get basic life support on the school agenda, on the school curriculum, because it's so simple to do. If everyone could do it, it would save a lot of lives. And we want to continue to support arrhythmia care around the world. We want to try and replicate our success in other places around the world where we've already been successful, like Australia, South America, etc., etc. So I'm going to shut up now, and thank you very much for being patient with me. And I'd like to introduce Jane Cowell, who's going to talk about the Partnership Care and Innovation to inform national guidelines.